Hello, and welcome to GAPNA Chat, an official podcast of the Gerontological Advanced Practice Nurses Association. GAPNA Chat provides interviews and discussions with GAPNA leaders and members of the gerontological healthcare community, and will focus on advocacy, policy, education, professional development, research, and clinical care for older adults. Before we get started, a practical guide for the gerontological specialist is now available for purchase in the GAPNA store. This text is a handy resource for anyone caring for older adults and is helpful to those preparing to sit for the Gerontological Specialist Certified exam. Visit www.gapna.org to get your copy. In this episode, Dr. Cassandra Vonnes, a gerontological nurse practitioner and member of the GAPNA Communication Team, talks with Dr. Stephen Posar, the founder and CEO of GuideStar Eldercare in Crown Point, Indiana. We are pleased to present Dr. Vonnes' interview with Dr. Posar.
Hello, everyone. This is Dr. Cassandra Vonnes, and today we have with us Dr. Stephen Posar. He has been a pioneer in developing systems of care for the frail, elderly, and chronically ill throughout his career. Dr. Posar is the founder and CEO of GuideStar Eldercare, a national leader in comprehensive care for neuropsychiatrically impaired dementia and neurological long-term care residents, providing them integrated neurologic, psychiatric, gerontologic, and psychological services. Dr. Posar has been named the Clinical Professor of Geriatric Neuropsychiatry and has co-developed, along with St. Mary's College, a Notre Dame University-affiliated institution, a very unique program for nurse practitioners that will educate and train them in the complex and specific care paradigm required for these patients. Thank you, Dr. Posar, for making time to join us today.
Well, thank you for inviting me. I've been looking forward to having this chat.
I've been reading a little bit about GuideStar, and your mission statement speaks to many of us that are involved in the care of older adults to enhance the quality of life for our shared patients by easing their suffering while actively promoting their safety, functionality, and dignity is what drives your care model. As an internist, what moved you to concentrate your focus on this vulnerable population with neurocognitive deficits?
Well, I was practicing as an internist gerontologist, and I was the medical director at a number of buildings. And one of the things that moves me personally is this whole notion of suffering, especially what is avoidable suffering. And at that time, and this was a while back, this is over 20 years ago, the real focus at that time was on the physical elements of suffering. This was when wound care and wound prevention was just beginning to come into its own. We were in the middle of an unfortunate detour about pain management using a lot of opiates. And it seemed at that point that there was a real effort looking at the physical elements of suffering in this population. So one of the things that I became aware of is that there was another element which was not being addressed virtually at all, which is the psychiatric, really the psychological suffering that these folks were undergoing. It was complex and multidimensional, and it started to move me deeply. And when I'm lecturing, and especially to a lay audience, the way I explain it is, think about the worst day you've ever had emotionally, psychologically in your life. Plug that into Groundhog Day, and you're living that same day over and over and over, and you don't have the cognitive firepower to work your way out of it. As I began to become increasingly aware of this, it just seemed like a working definition of hell. You know, if you've got wound pain or you're arthritic or you've had a trauma, we've got the tools available to deal with that. you have to recognize it, but you have to deal with it. But, one of the cases that moved me deeply was a screamer. And this was a gentleman in his late 70s who was sort of yelling all the time. He's wheelchair bound and almost frozen. And I went to examine him and spend some time with him. And over a couple of sessions, it became apparent to me that there was a real possibility that this gentleman had Parkinson's and had frozen man syndrome. And nobody was picking this up. No one was addressing it. And we put him on Cinemet. And, 2 weeks later, he wasn't yelling and he was able to talk and he was locked in and was able to express his distress. And it broke my heart. And that was really one of the seminal events that drove me in a different direction. Secondary case was basically, and if you're dealing with this population, you know that paranoid delusional states are very common if they become psychotic. Someone's going through my things, someone's stealing, whatever. And I ran across an individual, again, a male, who was constantly agitated and irritable, and nobody had talked to him about it. And I sat down and he was convinced that his wife was basically functioning as a prostitute and having sex with all these people, and it literally was driving him mad. And no one had addressed his psychosis and a very, very small change in his medication, and he completely changed. So those two cases were really index cases for me, and just started a whole process of wondering about what was really out there. And the eye cannot see what the mind does not hold. So I started thinking about this and talking to the patients and talking to the staff, and it became clearer and clearer to me that this was not a rare situation. It was actually standard operating procedure. What we now know from MDS data is, and the data is, it's silly, but the data from MDS is 98%, basically 100% of everybody at mid-stage in LTC will wind up with at least one axis 1 diagnosis. So the psychological elements of neurocognitive degenerative disease are literally universal, and nobody was addressing it. So that was really the motivation, which was this realization that this is close to a universal event. Subsequent research has indicated that greater than 50% of these patients not only will have an axis 1 problem, but it will be severe, that they're suffering, and that the definition in these studies was that they meet the criteria, Medicare criteria, for an acute inpatient psychiatric admission. And right now, we're admitting under 5%. So you've got this huge population of people that are being devastated by the psychological and psychiatric elements of their neurodegenerative disease, and it's completely being unaddressed. Secondarily, the data indicates that in that population, only 5% have a premorbid serious mental illness. So 95% of these people were fine until they got organic brain disease. And it's like, this is like having somebody with diabetes, and you've got the diabetes under reasonable control and don't check their lipids. Okay, this is something that's universal, which has incredibly horrifying consequences, and it's not being addressed. So it lit me up like a Roman candle.
And when I think about, you're talking about your experiences, and myself as a new nurse practitioner 25 years ago in long-term care, these symptoms, basically the team members in long-term care wanted to manage symptoms instead of looking at underlying causes. And we didn't have, physicians, we didn't have those skills, providers to evaluate the patients. We were just doling out chemical restraints, basically. How do you see that management of the behavioral and the psychological symptoms of neurocognitive disorders evolving?
Well, you go back 25 years ago, and I'm reluctant to point fingers because 25 years ago we had no science and we had no tools. The beginning of enough science to properly address this really began in about 2007, 2008, when the first studies came out looking at acetylcholinesterase inhibitors' impact on BPSD. The science continues to progress and the tools continue to progress, but I would be disingenuous if I said that there was really robust capabilities. We're in the infancy of the science. And, it's so confusing to even well-developed practitioners. I'll give you a couple examples. We, years ago, and we have, as part of my practice, my personal practice, I have a particular interest in the neuropsychiatric Huntington's disease. And we had a period where we were working in acute inpatient neuropsychiatric units. And one of the units was in a geography that was somewhat near a religious community that unfortunately had Huntington's as part of its environment. So we had a disproportionate amount of Huntington's. And we had a case that came in that was a mechanical engineer in his 40s with Huntington's, about 6'2", 6'3", very fit, and absolutely ragingly violent, uncontrollable. And we admitted him and tried everything we could to get him stabilized, and we failed miserably. At about that time, Nudexta had just come out, and in an act of utter desperation, I wish I could tell you that there was something scientifically robust about the decision, but it was, let's throw this against the wall and see if it sticks. So we gave him Nudexta, and within a week, he turned into a pussycat and completely stabilized and was able to go home. And this is the beginning of our interest in pseudobulbar. Nudexta, which is just cough medicine, it's just 20 milligrams of dextromethorphan with 10 milligrams of quinidine to help the penetration. Just cough medicine. But it's specific for pseudobulbar. It's a little bit like migraines when triptans came out. If someone comes in and says they've got wild monkeys shooting out of their ears, and you give them a triptan and the wild monkeys go away, it's a migraine. It's the same thing with Nudexta. If you give this to somebody and there's a behavioral change, by definition, it's pseudobulbar. So this became fascinating to us. And we subsequently got 8 more cases in the series. And 7 out of the 8 had complete response, 1 had partial, and 1 failed. But think about this. If this patient had come in 6 months earlier, there'd be no hope for him. So these little breakthroughs, these sort of odd things that happen, turn out in our world to give us a major opportunity to engage these patients in a constructive way. So what we see is increasing focus on this element. Partly, I think, I'm appreciative intermittently at what the government tries to do, and their focus on the behavioral health side for us is a boon. So partly this is being driven by the feds, but partly this is its time in the sun. It's time to look at this, and there's a growing appreciation for it. And it sounds ironic, but the current blow up with the presidency also is raising concern and interest in this population. God bless him, but our president's in serious trouble cognitively. So a lot of factors are beginning to evolve, and we're seeing the toolkit expand. Our concern is a lack of recognition. So we've gone from basically having virtually nothing except essentially chemical restraint to having a reasonable armamentarium, but for reasons that are, I think, structural, that is in general not made it to the bedside. It sort of floats out in the ether. So we just did a study which we've submitted for publication, looking at what percentage of patients that are eligible for these tools and have a demonstrated clinical need are actually getting the tools in their current environment. And sadly, what we're publishing is 6% of everybody who has potential to benefit from this is receiving that level of care.
Is that because in some cases, when you look at indication or off-label use, that the medical community is so driven by those randomized controlled trials, making a medication valuable for a set of symptoms, where in this case, maybe it needs to be case by case and presentation and, I don't want to say just anecdotal, but thoughtful, organized data in symptom management. Do you think that that has some benefit here?
Well, that's a great question, and it's something that we struggle with. I think that the answer is bifurcated. There is stuff that, as far as I can tell, we're the only people that know. And we preach it, we try and teach it, but it's not general knowledge. One example would be epilepsy. The literature on epileptology in this population is growing. It's actually relatively deep, but it's not particularly specific. So there's a big review study published last year, which indicated that 40% of dementia patients have an EEG, and there are all different ways of doing EEGs, but have some EEG evidence of an interictal pattern on their EEGs. And we actually believe this. We think that at least 30 to 40% of dementia patients have some form of seizure disorder. And it doesn't express itself typically with grand mal seizures. What we see typically is absence, they just space out. We think, actually, we know that this is one of the etiologies of falls, is seizures, where they just lose postural control and hit the floor. But the third is something called partial complex epilepsy, where they don't have seizures, they have behaviors. And very often, acute agitation is associated with these seizures. And to make matters even more interesting, you can have it during the seizure, and then you can have it postictally. So, and in truth, the literature's there, but unless you are a wonky guy like me, you're not into it. And we're trying to teach this, we're trying to bring it to light, which is one of the things that we're doing with the certificate program at St. Mary's, which is because, let's face it, this is a world that NPs are in the process of owning, and we're happy for that. I think that's a great resource. But we're trying to teach this. But there's another body of literature that's set, it's done. It's been out there for almost 20 years, okay? We know that a simple cocktail of an acetylcholinesterase inhibitor and memantine, Namenda, given to these patients as soon as you get them, will significantly mitigate PTSD. They either don't get it, or if they get it, it's milder and much easier to treat. We know this. This is set in the literature. Additionally, there's been a big study that indicates that galantamine, Razidine, if you use that for the acetylcholinesterase inhibitor, the study is highly suggestive that it slows the progression from mid to late stage. Okay, so when we did the study, that's all we looked at was, are they getting an acetylcholinesterase inhibitor and memantine? And the answer is 6%. And this is set. There's no controversy on this. This is 20-year-old information that's been validated over and over and over again. There's some controversy, very minor. We know that SSRIs also have a significant role to play in mitigating BPSD. But what we found, we were lecturing at a couple years ago at the American Association of Geriatric Psychiatry on our approach. And Cleveland Clinic was there at the same time, basically lecturing pretty much on the same thing. And they had a recommendation that you add SSRIs to the cocktail day one. We find that so many of the patients with some of the elements that we're working on do so well on the basic cocktail and then picking up these comorbid conditions that only about a third to a half of them really need an SSRI. So our approach is we start them on the cocktail immediately, and if they start showing BPSD, we add the SSRI. But it's a minor debate. But this is set. I mean, you've got Cleveland Clinic running around lecturing on this. You've got Mass General, you've got UCLA, they all know this. University of Arizona, the opinion leaders have been lecturing on this for 2 decades. And it just is not sticky. I don't know why.
I don't know whether it is the BPSD that they look at that group of medications, is it a benefit to slow the progression? And they only look at the cognitive part, not the behavioral part. How often do you think the BPSD symptoms, maybe episodes of delirium that are, super, a hyperactive type delirium, like with a urinary tract infection or some other process, hypothyroid, something that, may be causing the agitation?
Well, thank you for touching on that. That is, I'm actually in the process of preparing a major white paper on agitation in this population. I hope to get that done.
Yeah, agitation is not a diagnosis, is what I tell my students.
That's exactly right. It's a syndrome, and there are many causes, but I will pick on one in particular because it's a pet peeve. You get a call at 2 a.m. Mrs. Jones has woken up screaming and yelling, attacked her roommate, is attacking the staff, and we think she's got a UTI. And we've pulled the urine on her, and we're going to give her some Haldol and Cipro. And the probability of getting an accurate urine on an incontinent, combative 82-year-old who might have asymptomatic bacteriuria in any event, probably will, functionally is 0. They don't check for suprapubic tenderness because this woman's kicking and screaming and biting and scratching and flinging her poop. They can't check for costovertebral tenderness. They can't really get a decent urine sample, so they can't tell if there's red cells or white cells in the urine. But that's become, because there's bacteria in the urine, they make that assumption, and our opinion is that becomes urban mythology.
Yes.
In point of fact, what that lady has had is one in a series of microvascular strokes. I did an unpublished study many years ago where when we were doing the inpatient unit, we'd get these folks who are acutely agitated, and I had access to a CT, and we CT'd them. And 100% of them had high density white matter lesions. So if you look at pure Alzheimer's disease, which by the way is very uncommon, it's max 20%, and every time they redo the autopsy studies, the number gets smaller. But if you look at pure Alzheimer's, it's actually kind of in a strange way, a gentle disorder. It's slow, it's predictable. They're going to get anxious when they graduate, a little bit of depression, early stage. They get a little anxiety. It's easy to take care of. They're fine. They progress. It's gentle. They go to meet their maker, and that's it. When you see someone with AD who's bouncing off the walls, there's something else going on. And it turns out that at least 2/3 to 3/4 of these people have active beta amyloid microangiopathy, and they're getting a succession of wet and dry microvascular strokes. So what winds up happening is you get 20 these little things, and I put this in quotes, in dead areas of the white matter, and you don't really see it. They're a little less neurologically capable. It's subtle. You get one of these anywhere near your amygdala or near your cerebellum, you go into full launch mode, you blast off. So what you've got is an acute microvascular event in an area of your brain, which sets you off on a very, very unsteady course.
So no treatment. The purpose
treatment,
is to prevent this from occurring,
you
correct?
you can't prevent it. This is not atherosclerotic. What happens is the beta amyloid gets in the lumina of your vessels, gets in the vessel wall, and their small arteries. And as you know, the anatomy of the end arteriole is you lose your muscular coat, and then there's a little tiny piece of that that precedes the development of your capillary bed. So you've got this beta amyloid in the vessel wall, but the muscular coat protects it. So it just sort of sits there and stares back at you. But at the very end arteriole, you'll lose that. And it does one of two things. It either plugs that and you get a ischemic microvascular event, or unfortunately, the end arterial pressure is still enough with that weakened cell wall to blow out the vessel and you get a bleed. So we've tried on the inpatient side, when these people are showing these cascading strokes, nothing works. We've not found anything. The literature doesn't support anything. And when I've talked to opinion leaders in this world, they kind of throw their hands up and say, we're stuck.
What about statins? Because there's a lot of deep prescribing out there that's happening. And, it's always been a concern of mine if, some of the theories behind plaque stabilization, with statin use, and then, then someone is 85 and you say, oh, we don't care about their cholesterol anymore. Let's take them off of their Lipitor.
Atherosclerotic cerebrovascular disease is a real thing. And statins and aspirin and all of that has a role to play in and I put this in quotes, the normal geriatric population. The progression of these dementias, once you get to the point where you need to be in an institutional setting, is set. You cannot reverse it. What we know is everything that we've tried will not extend life. Even the new Alzheimer's drugs, all they do, and I'm not sure they even do this, all they do is slow the progression from early stage to mid stage. That's all they do. But nothing that we figured out extends life expectancy. So when I'm lecturing on this, you have to recognize that these people are going to progress no matter what you do, and they're going to progress at the same rate no matter what you do.
Okay. So we're not making them worse by stopping their statins, by deprescribing in their 80s.
The primary disease process is unassailable. It is just going to go, and God bless them all. It's going to take them when it's going to take them. So when I'm talking to professionals, I said, okay, very simple. You've got somebody with terminal small cell lung CA that's now failed therapy. Do you keep them on their statins?
No.
No. Okay. It's the same thing with these folks. It's tragic. I hate it, but we do not have any tools that will slow down the progression of these diseases. And, just looking at Alzheimer's disease, 25% of these folks have two causes, and 55 to 65% have three or more distinct etiologies for their dementia in the same brain. These are, basically at a sort of teleologic level, everybody dies of organ failure. Lots of different causes, but an organ you can't afford to stop, stops. Okay? That's what we die of. Well, we're fantastic with tickers. We can keep your heart going for a long time. We're getting better with lungs. We're doing incredible stuff with livers. Infectious diseases that used to be untreatable are now under control. Magic Johnson's had HIV for almost 35 years. Okay. We are doing great work. What's the one organ we haven't really figured out yet? And it just seems like at some point your brain just says, I'm done. I quit. And we just don't have the ability yet to make that a happier place for these patients. It's going to be a long, long struggle, which will outlive me. And I just feel like in the interim, anything that we can do for these folks that will make a significant difference in their quality of life is absolutely worth exploring and working aggressively to implement.
And your protocol, your antipsychotic stewardship program, begins with this multifaceted, approach to the person and their behavior and their assessment. Tell us a little bit about how that works. How did you implement this? And is there, besides the long-term care setting, if we utilize this in an ambulatory setting, could we keep patients in their homes longer with their care partners instead of institutionalizing them?
There are two key elements to this. One is the old saying, if you don't know where you're going, any road will take you there. The Oslerian dictum, there are three parts to internal medicine: diagnosis, diagnosis, and diagnosis. The first element is to understand that BPSD is a neurologic manifestation, not a psychiatric one. You have to appreciate that neurology comes first for 95% of these patients. So if your BFF calls you one day and says, Sandy, I don't know what the heck's going on, but I've got intermittent double vision and I've become heat intolerant and I've got tingling in my hands and legs and my legs are getting a little weak and I'm having trouble thinking and I'm really depressed. You're going to go to yourself, ooh, it sounds like my BFF has MS. And so you're not going to get on the phone and say, oh, go see a psychiatrist. You're going to say, here's a number of a really good neurologist that specializes in this. You'll get a blast of steroids, go on some biologicals, good chance you're going to go in complete remission. And then let's take a look at your depression and see if it's even there. You treat the neurology and then see what's left. That's the approach. Number two is you've got to make an investment in diagnosis. They're not dementia. Dementia is like saying they're agitated. There's half a dozen different diagnoses, each of which is going to have a different prognosis, different treatment approach, a different need for supportive measures, on and on and on. And then you get into secondary diagnoses: seizures, pseudobulbar, sleep disorders. Everybody hates dementia with Lewy bodies. And why? Well, they get it, in the middle of the night, they go crazy. It's like, okay, what they have is REM behavioral sleep disturbance. You know how you treat that? Wake them up. Okay, they're acting out their nightmares. That's why they're unstable. So if you don't know that, they scare the heck out of you. So you have to make a really hard effort at coming up with primary and secondary diagnoses, because almost, not all, but almost all of them have some form of ameliorative therapy. I was called in a consultation on a case of a 90-year-old who was the father of an internist. And he called me and says, I need you to take a look at my dad. He's in hospice and he's been horribly violent and screaming and yelling and attacking people. And we've had to sedate him and it's breaking my heart. And I went in and I took a look at him and I put him on Keppra. In 36 hours, he was awake, alert, talking, and happy. He had partial complex status epilepticus. Put him on an anticonvulsant, life is good.
And this goes without saying that, we're talking atypical presentation of seizure disorder when you're looking at those patients. We don't think of it that way.
I understand, but with respect, that is not an atypical presentation in this population. This is something, there's literature on partial complex status epilepticus. It's there. It's not getting to the bedside. We're not inventing this. It's there. You pick it up, carry it to the bedside, and you bring it to your patients, and their lives change. That's what we're trying to do. And that should be available to outpatients as well as folks in a care setting. It's the same illness, it's the same diagnoses. And the short answer to your question is yes. If you do this, they do better at each stage of the disease. Secondarily, we are super focused on deprescribing. Okay. The change in these folks' brains affects the way medications reach them. So an example is, and we all know about this, is anticholinergics. I just get rid of them. I mean, just get them out of there. Unless they've got an absolute cardiovascular need because of an arrhythmia, get them out of there. They're substitutes for everything that you're prescribing as an anticholinergic. And a lot of times folks do not understand that a particular medication is an anticholinergic. So one of our pet peeves is quetiapine, Seroquel. It is incredibly anticholinergic. Dr. Cummings, who's one of my favorite folks in this area, published a monograph 3 years ago that showed it doesn't even work. And the reason it doesn't work is the side effects are so harsh that it counteracts the positives. You give someone Seroquel, they will have a functional and cognitive and behavioral decline on the Seroquel. And if they're on the Seroquel for more than a month and stop it, they don't recover. There's just an article, which we're now circulating, which was published in Cardiac Rhythm, that indicated that Seroquel is a significant contributor to sudden death and ventricular arrhythmias. This drug is a flat out toxin. What is the most common antipsychotic prescribed in long-term care? Quetiapine.
Mm-hmm.
So you really have to pay attention to polypharmacy.
Is this part of your curriculum with, educating the nurse practitioners about the cholinergic burden of some of the medications we use, and how are you going to change this? How are you going to change this mindset?
Teaching, publishing, preaching. I mean, it's all we can do. I mean, we're leading by example. Another example, which is extraordinarily common, is treating diabetes. Another cause of acute agitation is hypoglycemia. You know this. You give someone insulin, if they become hypoglycemic in the middle of the night while they're asleep, they're going to wake up and just be bouncing off the walls. And if someone becomes hypoglycemic at night, they'll typically be hyperglycemic in the morning through the Somogyi effect. So they get all these stress hormones released. So their sugar in the morning shoots up. Someone grabs the sugar on them in the morning and say they're not getting enough insulin. So these things become self-perpetuating. And, as an internist, I talk to people and say, okay, how long is it going to take somebody to develop a significant diabetic complication if their sugars aren't tightly controlled? Oh, well, how about 10 to 15 years? Most of these patients may not have 10 to 15 months.
Yeah.
Why are you worried about their blood sugars? Okay. Hypoglycemia is a much greater risk for these people than hyperglycemia. Hypotension is a much greater risk than hypertension. Back off. They don't need all of this. The rules are different for these folks. When I was in medical school, they used to preach that kids are not little adults. Our patients are not old adults. They're their own thing. And the rules are different. So deprescribing is a huge issue and a huge benefit for these people.
Wow, I've learned so much. We're gonna have to, meet again. I've still got so many, talking to you. I've got more questions. Our pharmacology conference next year, we'd love to have, maybe some presentations. Our general conference is in Vegas next year in September. So love to have some more discussion about this. And any closing thoughts for our audience, Dr. Posar?
Yeah, the view from 20,000 feet about why we're not making this routine practice for our patients in need. And in terms of my people, I give them a homework assignment to read a particular book. And they all get ticked off at me when I make them do it because it's kind of dry. It's called The Structure of Scientific Revolution by Thomas Kuhn, Kuhn. It was written in the 60s. And it's the book where the concept of paradigm shift was invented. And one of the things that we know about paradigm shifts is they're always resisted. And the best explanation I can give to you for why we're in the situation we're in is that we have a paradigm that made sense 30 years ago, 20 years ago, but we've outgrown. And getting that shift is hard, it's difficult. And Kuhn talks about it. And if you have any interest in these kinds of sort of dry intellectual philosophical views, I highly recommend the book.
And what was that title again?
The Structure of Scientific Revolution.
Okay, got it. Well, I've got some summer reading to catch up on, and thank you again, Dr. Posar. I really, really appreciate you taking some time for us, and thank you all for joining us for this GAPNA chat, and for all of you listening. Until next time, as you take care of others, remember to take care of yourselves. Thank you.
GAPNA Chat is owned and produced by the Gerontological Advanced Practice Nurses Association. All rights reserved. No portion of this podcast may be used without written permission. If you are an advanced practice nurse caring for older adults and want to further your career, GAPNA encourages you to sit for the Gerontological Specialist Certified exam and earn your GSC credential. This expert certification distinguishes APRNs with the knowledge and experience to manage the complex health needs of older adults. Visit gerocert.org to learn more. Dr. Stephen Posar is the founder and CEO of GuideStar Eldercare in Crown Point, Indiana. Dr. Cassandra Vonnes is the Nurses Improving Care for Healthsystem Elders Niche Coordinator, Geriatric Oncology at the Moffitt Cancer Center in Tampa, Florida. She is a member of the Gerontological Advanced Practice Nurses Association Communication Team and is a host of the GAPNA Chat podcast series. For archived episodes of GAPNA Chat and to learn more about the Gerontological Advanced Practice Nurses Association, visit gapna.org. You can also subscribe to GAPNA Chat everywhere podcasts are found.